Good morning, ladies and gentlemen. The topic of today's lecture is Principles of Cutaneous Laser Therapy, Part 2. In today's lecture, first I'm going to discuss the differences between IPL and lasers, and then I will discuss the laser tissue interactions and the important lasers and their side effects in two important dermatological indications, that is the vascular lesions and pigmentary lesions. So let's proceed with today's lecture. Flash lamp or intense pulse light, commonly known as IPLs, they emit a broad range of spectrum of light, that is 500 to 1200 nanometer. These devices are cheaper to manufacture than the lasers and can be used with light filters to allow a potentially wide range of applications. It is possible to vary their pulse duration from 0.5 to 88.5 milliseconds. This wide range of pulse duration is also helps in increasing the range of these IPLs, and to introduce interval between the pulses of 1 to 300 milliseconds. This interval helps in protecting the epidermis from getting damaged. IPLs are not a substitute to laser, where focused high energy beams are required, but otherwise they are a good alternate to laser therapy. Few differences between lasers and flash lamps or IPLs. Laser emit a single wavelength. For example, a pulse dye laser emits 595 nanometer wavelength. Flash lamp will have multiple wavelengths tuned according to application. That is, these multiple wavelengths are cut off by use of cutoff filters, and hence specific wavelength of light is emitted from a flash lamp. Lasers have a small circular square shaped spot size, while flash lamps or IPL have a larger rectangular or square shaped spot size, which is also known as the footprint. Lasers have higher repetitive rate, that is higher hertz. However, the flash lamp will have low repetition rate or low hertz. Lasers come with a smaller handpiece, while flash lamps come with a bulkier handpiece, which houses a lamp and a lamp cooling device. Lasers emit single pulses of variable or fixed duration for efficient heating of the target. On contrary, flash lamps will emit multiple pulses with variable or fixed delay for slow heating of the target and sparing the epidermis. Before putting a patient on a specific laser therapy, there are a few general considerations which you should all know. The lasers have a range of indications which are steadily increasing over the years, and the treatments are becoming safer, effective, and better tolerated. Dermatologists should be able to clear the perception of patients regarding laser and their benefits and side effects. Usually the patients carry different kind of perceptions, and most of them think that one session of laser is sufficient for their disease. And it should be made clear to the patients that they require multiple sessions and the results can never be 100%. Avoid dysmorphophobic patients and those with unrealistic expectations. But if you are unable to avoid such patients, then it is better to take before and after photographs. For established indications, it may not always be possible to predict the outcome with any degree of certainty, and hence realistic goal should be set for treatment. So for general consumption, promise the patient 50 to 70% of improvement after 5 to 6 sessions of lasers that are used for different indications. Vascular lesions and vascular lasers. First, the light tissue interaction. The main absorption peak of oxyhemoglobin is 418, 542, and 577 nanometer. A flash lamp pumped dye laser with a wavelength of 577 nanometer, a pulse duration of 0.3 millisecond, and fluence of 2 joules per centimeter square is used initially. In subsequent treatment of port wine stain, this wavelength is replaced with 585 to 600 nanometer wavelength, and this has an advantage of deeper penetration. A slightly longer pulse duration of 0.45 millisecond was used in the first generation of pulse dye laser on the basis of calculated thermal relaxation time of less than 1 millisecond for vessels with a diameter between 10 to 50 micrometer. These are the small blood vessels which are located mainly in the papillodermis. So for targeting the vessels in papillodermis in fresh or early port wine stain, that is in an infant, the pulse duration of 0.45 millisecond is sufficient, as this pulse duration will be able to target the vessels twice, as the vessel have a thermal relaxation time of 1 millisecond. Pulse dye lasers are now manufactured with a range of pulse duration from 0.45 millisecond to 40 milliseconds. Though shorter pulses of PDL is optimal for port wine stain in children because the vessel diameter is small, the larger pulse duration is used while treating port wine stain in adults when the vessel diameters is large. So the new and modern pulse dye lasers are able to target the vessels both of smaller size in infants and children and of larger size in adults. Another laser useful for facial telangiectasias is potassium titanyl phosphate or KTP laser, which operates at a wavelength of 532 nanometer. Light from this laser does not penetrate beyond superficial vessels and is well absorbed. These are the other devices which are used to treat the vascular lesions. Copper vapor 578, KTP 532, pulse dye laser that operates at various wavelengths, which is 577, 585, 590, 595 is the most common, and 600. Alexandrite will always operate at the wavelength of 755 and ND-YAG at wavelength of 1064. Then diode lasers are also used to treat the vascular lesions, and various wavelengths like 800, 810, 930, and even 980 nanometer is used. Flash lamps, which are not the lasers, they operate at a wavelength of range between 515 to 1200. These lasers are widely used with or without cooling device to treat small facial vessels. Now, briefly discussing various devices that are used to treat the vascular lesions. Pulse dye laser between a wavelength of 585 and 600 nanometer. These lasers contain rhodamine dye that is excited by a xenon flash lamp to produce a light with a pulse duration of 0.45 millisecond, that is short pulse PDL, or light with a wavelength of 1.5 to 40 millisecond, which is called as the long pulse PDL. Spot size can vary up to 12 millimeter. Light penetrates the dermis to the depth of 1.2 millimeter and photocoagulates the vessel up to 100 micrometer in diameter. For smaller vessels which are less than 50 micrometer in diameter, we use short pulse PDL. And for vessels with diameter around 100 or more micrometer, we use long pulse PDL. Then flash lamps. Flash lamps emit wavelength between 500 to 1200 nanometer. They emit a non-coherent light over a broad spectrum. So various cutoff filters are used to treat the vascular lesions. These filters are 550, 515, 550, 570, and 590 nanometer. These devices have bigger spot size, hence larger area can be treated efficiently with less discomfort. Potential advantages are reduced likelihood of purpura or overcorrection when treating fine facial telangiectasias or diffuse facial erythema. For treatment of vascular lesions, topical anesthesia is usually satisfactory, but local and regional anesthesia may also be required. For infantile hemangiomas, that is capillary hemangioma, use of laser is now rarely indicated because initially such patients are treated with medical treatment, and that is with propranolol, 1 milligram per kilogram body weight, can be given for more than 6 months. Infantile hemangiomas have shown a reduction in both erythema and size when treated with pulse dye laser or ND YAG. Port wine stain. A PDL is the intervention of choice, and 6 to 8 treatments spaced at 4 to 6 weeks will achieve good result in as many as 60% of the patients. PDL have been manufactured with longer wavelength, larger spot size, and longer pulses, as well as with cooling device that allow use of higher fluence. Lesions become purpuric if treated with both high fluence and pulse duration of 6 milliseconds or less. Although reduced by cooling and longer pulse, the degree of post-treatment purpura formation is thought to be necessary for effective treatment of the lesions. So the end point of a good laser treatment with PDL for a vascular lesion is purpura. Factors favoring good response to PDL treatment are youth, that is younger child, flat or scarlet colored lesion rather than purple colored lesion, and the lesions on head and neck region. And factors that cause poor prognosis or poor prognostic factor with poor response to treatment include age over 1 year, central facial lesions, the lesion of size more than 40 centimeters square, nodular or hypertrophic lesions, lesions with vessels which are greater than 400 micrometer in diameter at dermoepidermal junction, and there have been more than 5 previous laser treatments. Flash lamps have larger spot size and have been used to treat resistant port wine stain with supposedly good effects. So these are the few images. This image shows treatment of ulcerated hemangioma after 2 sessions of PDL. Then this is a good response in which PDL was used to treat port wine stain. In 4 sessions, the lesion is almost diminished. Telangiectasias. Spider telangiectasias are probably best treated with PDL. Superficial telangiectasias that are commonly found on mid-face respond safely and well to single treatment with KTP laser. KTP laser treatment do not produce purpura and hence are more acceptable to the patients. More diffuse, finer telangiectasias or erythema will respond to PDL treatment. Then this is the response of facial telangiectasias with a few sessions of PDL. Leg veins. Some superficial small caliber venules respond to laser treatment. Longer pulses of PDL, that is in the range of 1.5 millisecond to 40 millisecond, is used, and wavelength is 585 to 600 nanometer and with moderate fluence. For vessels of greater caliber, these lasers are used but in endovascular mode. Then 800, 940 or 980 nanometer diode is also used to treat small superficial leg veins. Complications are relatively common and include ulceration, depigmentation, and scarring. This is before and after treatment of leg veins with PDL. Miscellaneous vascular lesions. For angiomas and venous lake, PDL is treatment option. Small red angiofibromas respond well in younger patients with tuberous sclerosis, in whom ablative treatment is inappropriate. But as the angiofibromas become skin colored and larger and patient is older, then we go for ablative laser treatment. Pyogenic granulomas should be better treated with cautery or curettage rather than with PDL. So this is the before-after picture of angiokeratomas treated with PDL. There are few other non-vascular indications of PDL. The first is the viral wart. Pulse dye laser are used to treat viral wart at higher fluence without cooling. The rationale is to photocoagulate the underlying dermal vessels and hence compromise the viability of abnormal epidermis. Facial and perineal warts are treated better than the plantar warts. There is no evidence to suggest that laser treatment offer a better chance of cure than the traditional treatments like cautery, cryotherapy, etc. So this photograph shows improvement of a plantar wart after 4 PDL sessions. Other indications include hypertrophic scar. PDL have been reported to improve the color and contour of erythematous and hypertrophic but not keloidal scars. Mechanism is also the destruction of superficial blood vessels, compromising the blood flow, claimed to be most useful after the scar have first been substantially reduced by intralesional corticosteroids. Overall evidence seems to be poor for use of lasers in this indication. Psoriasis. Localized and resistant plaque psoriasis has been reported to respond to treatment with either shorter or longer pulse 585 nanometer PDL. Although non-toxic, treatment is often painful and can cause dyspigmentation and scarring, which are the usual side effects. Granuloma facial also respond to PDL treatment, but the mechanism of action is not very clear. These are a few complications of the vascular lasers. Post-inflammatory hyperpigmentation or purpura is the most common side effect. Both atrophic and hypertrophic scarring can occur. Erythema, pallor, discomfort, vesiculation, and crusting can follow KTP laser treatment. Atrophic scarring reported treatment for nasal telangiectasias. Non-purpuric PDL parameters may result in significant facial and periorbital edema. Then, tattoos and pigmentary disorders. Light tissue interaction. Melanin absorb light in ultraviolet range, that is about 1200 nanometer. At a shorter wavelength, absorption is higher, but penetration is less deep than at the longer wavelengths. The therapeutic window for treatment of pigmentary lesion lies between 630 and 1100 nanometer. Waves of QSwitch are designed to be within the estimated thermal relaxation time of melanosomes, which is 0.5 to 1 microsecond. So thermal relaxation time of melanosome is very short. So for treatment of or destruction of melanosome, we require ultra short duration wavelengths And these wavelengths will be a little longer than for tattoo particles. Pulses in nanosecond range may fragment and disperse melanin and tattoo ink, thereby altering their optical properties. Some may also be eliminated by transepidermal elimination. Devices that are used for treating tattoos or the pigmentary lesions. The first and the most commonly used device is the QSwitch YAG laser 1064 nanometer or double frequency YAG 532 nanometer laser. The light that penetrates 2 to 3 millimeter into the dermis and therefore is suitable for treatment of deep dermal pigmentation. If frequency is doubled and wavelength half to 532 nanometer, penetration is reduced and therefore more useful for removal of epidermal pigment. Then QSwitch Ruby laser 694 nanometer and QSwitch Alexandrite laser 750 nanometer and diode 810 nanometer. All these lasers emit red light at intermediate wavelengths, allowing somewhat deeper dermal penetration with some loss of absorption. So all of them are effective for deep dermal pigment. Then the flash lamps, 500 and 1200 nanometer, they emit a non-coherent light over a broad spectrum with potential advantage in terms of penetration and absorption. Indications of laser treatment for tattoos and pigmentation. QSwitch treatment of tattoo is cosmetically superior to older destructive modalities. Blue or black tattoo pigment absorb across a broad range of wavelengths and are best treated with QSwitch. Green ink respond optimally to QSwitch Ruby and QSwitch Alexandrite lasers. Red ink respond best to green light emitted by QSwitch YAG laser 532 nanometer wavelength. Yellow or pastel colors are difficult to treat and complete resolution is unusual. So the nanosecond domain pulses may be too long for certain tattoo particles, and hence picosecond pulses are developed in pico laser, which are more effective in treating tattoos as compared to QSwitch. So these are few images of before after treatment with a pico laser or QSwitch laser. Endpoint of such treatment is white color frosting over the lesion. Epidermal pigmentation. The affiliates of freckles and actinic or soral lentigens respond well to the treatment with QSwitched KTP laser 532 or QSwitch frequency double laser 532. These lasers can cause bruising, and facial lentigens as well as the labial lentigens associated with Peutz-Jeghers syndrome have been shown to improve with QSwitch Alexandrite lasers. These are the freckles that are treated by QSwitch laser. Dermal pigmentation. Speckled or lentiginous nevus or speckled nevus, Caffole macules or compound nevi are all treated with QSwitch YAG laser at wavelength of 1064. Nevus of Ota is best treated by QSwitch Ruby, Alexandrite and YAG. Flat, medium-sized congenital melanocytic nevi respond to pigment-specific lasers, but raised lesions only improve with ablative laser treatment. Melasma. Melasma can be epidermal, dermal, or mixed type. Dermal melasma is the term which is used for pigmentation which is deeper in color in the epidermis and some pigmentation in superficial derms. These these are quite a resistant pigmentation and usually unsatisfactory to QSwitch laser therapy. But since the disease is very chronic, persistent, and patients have a lot of psychological issues with the disease, so these treatments are worth trying. As with melasma, the response of post-inflammatory hyperpigmentation to laser is unpredictable, and there is a significant danger of increased skin pigmentation. This is mainly done if high fluence of light is used and patient does not follow the instructions after the laser treatment, and by giving such treatments at shorter interval of time. Drug-induced hyperpigmentation secondary to administration of minocycline or amiodarone respond readily to the treatment with QSwitch, Ruby Alexandrite, or ND-YAG laser. So the response of treatment is better in drug-induced pigmentation. So the laser treatment for melasma has different dynamics, and there are several studies that use IPL, ablative laser, or non-ablative fractional laser, QSwitch at 1064, QSwitch at 694, and picosecond devices as a treatment for melasma. There is a recent evidence to suggest that there is a vascular component related to melasma, and treatment of this vascular component by PDL help in treatment of the melasma. IPL has a wavelength that ranges between 515 to 1200 nanometer and is thought to be beneficial in treatment of melasma as it can target both epidermal and dermal pigmentation because of the range of wavelength. Various studies gave a 23% improvement with IPL alone versus 57% improvement if IPL is combined with other topical treatments. Another study reported more than 51% improvement with 4 consecutive sessions of IPL. The fractional lasers, non-ablative fractional lasers, create microthermal zones of controlled skin damage that results in more rapid skin recovery, reduced risk of scarring, and both non-ablative fractional laser and ablative laser technologies have been used for treatment of resistant melasma. A 1927 nanometer device known as the Fraxel Duo, which operates at 2 wavelengths, 1550 and 1927, is more extensively studied specifically for epidermal and superficial dermal hyperpigmentation. The high recurrence rate and lack of blinded studies, lasers should be used as a second-line therapy only after rigid topical treatment have been tried. The QSwitch laser provide a shorter pulse duration with higher energy intensity. QSwitch lasers that target melanin includes Ruby Alexandrite and ND-YAG. The initial studies were somewhat disappointing as majority of patients experienced significant post-inflammatory hyperpigmentation and worsening of melasma. However, the new technique of low-fluence QSwitch is now being studied at a wavelength of 1064 nanometer with promising results. That is 92.5% improvement with 5 consecutively weekly sessions. So the low-fluence lasers can be used for weekly sessions. Hyperpigmentation is another side effect, again occur when a high fluence laser is used, and this hyperpigmentation takes a lot of time to clear. And whatever is the result of laser treatment for melasma, there is 100% recurrence rate of melasma. So just make the patient clear that use of lasers for this treatment does not guarantee that the pigmentation is not going to return back. More recently, a new class of laser, that is a pico laser or picosecond laser with even shorter pulse duration, has been studied. It is thought that a shorter pulse duration, there is more of the sub-thermolytic photoacoustic damage that can selectively target pigment without destroying or excessively heating the surrounding tissue. This seems to represent a potential treatment alternate for melasma with less cutaneous side effects like dyspigmentation. This could be particularly true if used in combination with topical therapy and used with fractionated handpiece. So regarding melasma, it is concluded that it is notorious and hard to treat condition, and treatment should be personalized to each individual. The most successful approach is to rely on combination of sunscreens, lightening topical products that include hydroquinone, transamine, kojic acid, glycolic acid, retinoic acid, and superficial chemical peels with laser or light therapy, and sometimes even with oral transamine. IPL low fluence QSwitch 1927 nanometer non-ablative lasers, fractional lasers, and picosecond treatment with variable success. However, the decision of whether to use laser is still up for argument. A few complications of pigmentary treatment of pigmentary lesions with lasers. The most common is the laser burn, dyspigmentation, or scarring. Dyspigmentation includes both hyper and hypopigmentation. Erythema or pinpoint bleeding are common and expected, and they resolve in a couple of days. Certain tattoo pigmentation even can get darker with laser treatment. In congenital melanocytic nevi, high recurrence rate is a recognized problem because something is definitely left even after the laser treatment. So I thank you all for today's listening and see you next time with the last part of this lecture. Goodbye and have a good day.